Hello and welcome to the Binding Sites webinar titled New Diagnostics and Therapeutics for the Management of Patients with Monoclonal Gammopathies. Today we have with us Dr. Linda Traylor and Dr. Paul Miller. Dr. Miller is Distinguished Clinical Professor of Medicine at the University Medical School in Denver, Colorado. In addition, Dr. Miller is the Medical Director of the Colorado Center for Bone Research in Lakewood, Colorado. After receiving his medical degree with distinction from the George Washington University School of Medicine in Washington, D.C., Dr. Miller became an intern in medicine and chief medical resident at the University of Rochester School of Medicine in New York. Subsequently, he completed a clinical fellowship and research fellowship in the Division of Renal Diseases at the University of Colorado Medical School. Treatment of osteoporosis in postmenopausal women has been the primary focus of Dr. Miller's research. He is now principal investigator of a number of clinical trials evaluating the safety and efficacy of various therapies now used or considered for use in these patients and renal bone disease. Based on his research, Dr. Miller has authored and co-authored more than 300 peer-reviewed publications and book chapters. He has contributed his work to the New England Journal of Medicine, Journal of Clinical Endocrinology and Metabolism, Journal of Bone and Mineral Research, Osteoporosis International, and the Journal of the American Medical Association. Notably, Dr. Miller is editor-in-chief of the Journal of Clinical Densitometry, as on the editorial board of Osteoporosis International, Calcified Tissue International, the Journal of Women's Health, and the National Osteoporosis Foundation's clinical newsletter. A fellow of the American College of Physicians, Dr. Miller is a member of numerous professional organizations. He was a founder of the Metabolic Bone Disease Society of Colorado and also the founding president of the International Society for Clinical Densitometry, for which he is now Emeritus-in-Chief of the Journal of Clinical Densitometry. Dr. Miller has served on several national and international committees related to osteoporosis and bone disease to enhance research and education. Dr. Miller has received numerous awards for his professional contributions, including an honorary doctorate of science from Gettysburg College in Gettysburg, Pennsylvania, Distinguished Alumni Award from the George Washington University School of Medicine, the Lasker Award from the Colorado chapter of the American College of Physicians, and most recently, he was awarded the Career Achievement Award and the Distinguished Clinical Professor Promotion by the Department of Medicine of the University of Colorado Medical School. Dr. Miller, it is a pleasure to have you here. I will now turn it over to you.
And welcome, folks, to this the program on new diagnostics for patients with monoclonal gammopathies. And many of you who may know me may be wondering why I, as a non-hematologist oncologist, am giving this program. And it has to do with the fact that, as you'll see as we go through the slide set, that a lot of the patients that we see as a referral practice for different metabolic bone diseases end up having some type of monoclonal gammopathy, and then we're challenged with the issue of trying to decipher what's going on, and also because, as you'll see from some of the data that I'll show you, a lot of these people, even with monoclonal gammopathy of undetermined significance, or MGUS, will fracture. And this is a whole world of secondary causes of osteoporosis that we need to be alert to. So that was some of my background. And here I'm a nephrologist by formal training, and cardiac nephrologist, although I haven't done active nephrology for about 20 years, but I did do it for 20 years. And I still do a lot of the metabolic bone work for the renal patients, including the bone biopsies quantitatively to distinguish among the different kind of bone diseases that renal patients can get. So a lot of the answers that I might, and some of the points of view that I have are biased by obviously the type of practice that I have. This is a referral practice. We see a lot of obviously routine types of osteoporosis, as well as a large number of people that are referred who have complex problems with regard to the causes for their osteoporosis. And so we routinely order an extensive laboratory workup, because we're seeing people that are fracturing despite taking bisphosphonates, or who have some impairment in renal function. So with that as a background, I think it's important to keep in mind, this is a nice little paper from the Quarterly Journal of Medicine in 2007, and the title of this is "Myeloma Patients May Present to a Range of Specialties Depending on Their Symptoms." The point of the slide is here, and that is, in this particular study, 55% presented to general practitioners versus hematologists or oncologists, which shouldn't be necessarily surprising, because a lot of these patients will present with fractures or present with an unexplained anemia. And but I think the important message is that everybody that could be of different fields should be on the alert for these particular conditions. So this particular slide says, who sees the multiple myeloma patient first? Well, the primary care physicians, internal medicine, will often see them because they have the new appearance of an anemia, or on their chem panels, the new appearance of hypercalcemia. We see them because they have a lot of fractures, or because because they have very low T-scores, or the bone density value that was established in 1990 or published in 1994 by the World Health Organization for the diagnosis of osteoporosis based on bone density criteria. The orthopedic surgeons, obviously people that have fractures, or rheumatologists because of the patients who have elevated SED rates or high CRPs. So, and obviously the renal patients who could have deposits of light chains or myeloma proteins in their kidney, or even amyloidosis. So there's a whole spectrum of how these people can present. Now, this is a slide that comes from actually from a paper in the JCEM by Tannenbaum, but also it kind of summarizes some of the guidelines from the National Osteoporosis Foundation about the evaluation of secondary causes for osteoporosis. And on these, you'll see that there's the chem panel, there's the CBC, the vitamin D level, which should be a standard of care in the evaluation of these patients. 24-hour urine calciums are recommended because a lot of these people can be hypercalcuric or have low urinary calciums that have osteoporosis, particularly if they have celiac disease. And then targeted laboratory tests. So the targeted laboratory tests are the things that we routinely do in our primary workups, and that is measuring the intact parathyroid hormone. We order the serum immunofixation as well as the serum FLC, which is the serum-free light chains, and we'll give you the rationale for doing that. You could also order, according to guidelines, a serum protein electrophoresis and an FLC. The combination is recommended rather than alone, and I'll give you the justification for that in a few minutes. We do celiac disease testing. We order the bone-specific alkaline phosphatase because we're seeing a lot of patients who could have Paget's disease or metastatic cancer to the bone. And, of course, the biochemical markers of bone turnover, which we'll talk about in a few minutes, such as the collagen cross-links, the C-telopeptide, which reflect levels of bone turnover. And then there are much more complex laboratory testing that people can order, which are not a part of even a secondary workup for osteoporosis, such as IGF-1 levels or fibroblast, FGF23, fibroblast growth factor 23. So what is a monoclonal gammopathy? It is a single monoclonal gamma globulin spike that can be seen sometimes on the SPEP, the serum protein electrophoresis, more often, in terms of sensitivity, on the immunofixation. And why it's called mono is because it's coming from a single clonal-derived plasma cell line. And this is although your right-hand side, this is what a regular serum protein electrophoresis with a monoclonal protein spike would show. and would come back in that pattern. Now, how common is monoclonal gammopathy in patients that are evaluated for osteoporosis? This is the summary slide of 4 different papers, and I think the most powerful one here in terms of the sample size is the paper in the New England Journal by Kyle from the Mayo Clinic, and because they had a sample size of 21,000 people. And I think other studies are fairly consistent with this, that it looks like that in the general population, not necessarily in the referral population, but in the general population, 3% of the population over the age of 50 and about 5% of the population over the age of 70 had MGUS from that Olmsted County data. This slide even focuses a little bit more in terms of the specificity of the type of population to those that present with an acute vertebral compression fracture, where obviously these people can be assumed to, for example, in the postmenopausal population that are estrogen deficient to have postmenopausal osteoporosis. But in this particular study, not a large sample size, and about a fourth were men, but close to 20% had a monoclonal gammopathy. We looked at our own practice, and we also have about 20% of referred patients who have fractured that have a monoclonal spike. Now, some of those are biased because they have some renal failure where there may be abnormal ratios because of the decreased GFR. This is another paper looking at myeloma screening populations in terms of when you should consider, if you're not routinely doing SPEP and FLCs, the patients with unexplained osteoporosis from your routine lab or low bone density who have fractures. It says here on this particular bullet, prevalent vertebral fractures, but I would expand that to include other types of fractures as well, hip fractures, non-vertebral fractures, fractures of the skull or the hands or the feet don't count, but people with unexplained humeral fractures, pelvic fractures. A bone density that's lower than the expected age, that's the so-called Z-score, not the T-score. If it's more than 2 standard deviations below the age-matched mean, then there's potentially a higher probability of having a secondary cause of osteoporosis beyond age-related bone loss. People that have unexplained anemias, obviously, unexplained elevated SED rates, unexplained impairments in GFR, and obviously hypercalcemia. So here is a menu of choices in terms of when you should be even more on top about ordering an SPEP or an immunofixation plus a serum-free light chain. Now, you know, SPEPs are good. They will often show this is an SPEP that's normal, and all the way over to the right side is the gamma globulin. But when you look at data comparing the sensitivity of SPEP versus immunofixation by itself, the serum protein electrophoresis can miss about 50% or more of light chain monoclonal disorders. And this is why, in part, doing an SPEP plus a serum FLC is an important combination, or an immunofixation plus a FLC is important in terms of the sensitivity of detecting these monoclonal diseases. So here's a lab report, for example. This is from one of our patients. This is a immunofixation that is normal. An M spike at the top was not observed. And so this is a negative normal immunofixation. Here is one that is a positive one, that's abnormal. You can see there's an M spike there. The absolute value in terms of gram per deciliter is still low, but it was present. And this particular patient had an immunofixation that showed an IgG monoclonal protein with a lambda light chain specificity. So this comes back on the lab reports in this particular manner. Now, in the evaluation of the osteoporotic patient, or if you're a hematologist, oncologist, in the evaluation of these people that have unexplained anemias or unexplained hypercalcemia, or it could be in your general internal medicine or family practice situation, we have data that the sensitivity for picking up the monoclonal gammopathy, whatever it could be, MGUS or myeloma or another monoclonal disease, is higher if you order either an IEP or SPEP plus the serum-free light chain, then ordering the immunofixation or SPEP without a serum-free light chain. It increases your diagnostic sensitivity. A monoclonal protein can be either an IgG, it could be an IgM, it could be an IgA, or it could be simply the secretion of large amounts of kappa or lambda light chains. Okay, so here you are in clinical practice, and you now have this monoclonal protein that comes back on your SPEP or your immunofixation. Now what do I do? Well, here is from the Mayo Clinic proceedings, and in their population from Olmsted County, a breakdown in 2008 of the differential causes of a monoclonal gammopathy. And you'll see in the yellow that the vast majority of these were MGUS, monoclonal gammopathy of undetermined significance. There were 17% that did have multiple myeloma. And of course, the challenge with us who are not oncologists, hematologists, is how can we improve the discrimination between myeloma and MGUS, or how do we have a prognosis for these people that look like they have MGUS in terms of counseling them about their future. Well, here is two nice slides from two nice papers that are referenced here from the Mayo Clinic proceedings in 2004 and 2009. And monoclonal gammopathy of undetermined significance, or MGUS, is the most common plasma cell disorder. As we mentioned, it's about 3% of the population over the age of 50, and it may be 6 to 7% of the population over the age of 80. And here is the definition. It is defined as the detection of a monoclonal protein, but with either no M protein or a serum M protein like the one I showed you previously, of a value of 3 grams per deciliter or lower, small amounts of monoclonal light chains in the urine, and a proportion of plasma cells in the bone marrow of 10% or less in the absence of bone lesions. These people usually, they can have osteoporosis and fracture, but usually do not have osteolytic lesions, anemia, hypercalcemia, or renal failure related to the MGUS. Now that's a little complicated, I think, involved definition, but that's the clear-cut definition. And of course, in this definition is the requirement of having a bone marrow of less 10% or less. But not all of these people may or may not necessarily require a bone marrow. And when we send a lot of people to our hematology colleagues here in the Denver area, sometimes because the predictive value of whether they have MGUS or myeloma really suggests MGUS, they may not even want to perform that. The serum-free light chains, or SFLC, there are 2 forms. They come from different clones, genetically derived clones of plasma cells. They secrete either kappa or lambda. They can be monoclonal, such as you see in myeloma or MGUS, or polyclonal, where you have lots of both, which you see particularly in inflammatory disorders or in patients that have renal impairment. You can draw the blood, you don't need to freeze it, and the serum-free light chains are covered by Medicare and most commercial plans. So here's an example. On the left are 2 plasma cells that secrete the monomer, the kappa, and on the right, the dimer, the lambda. And these are normal ranges that have been established in normal reference populations between 3.3 and 19 and 5.7 and 2. And then there's the kappa to lambda ratio. And the normal kappa to lambda free light chain ratio goes from 0.26 to 1.65. And the reason that the ratio is important is because it allows us to give a prognostic value for the future of some of these patients and be able to have some predictive models of who may progress in the future into multiple myeloma. So again, the question comes down to why order an immunofixation or an SPEP and an serum free light chain. The combination is more sensitive for the detection of immunoglobulins. The serum free light chains is more detection of free light chains by electrophoresis, not quantitative for light chains in the serum or the urine. And the combination is better than either one alone for discrimination and for prognosis. So here is a slide looking at the sensitivity analysis for light chains. And you can see on the vertical axis the light chain concentration. And across the horizontal top bar is the sensitivity for light chains by SPEP, by serum immunofixation, by urine protein immunofixation. And you'll see that the greatest sensitivity, even down into the normal ranges, is achieved with serum-free light chains. Now, the serum-free light chain ratio, they are not diagnostic for discriminating between MGUS and multiple myeloma. The importance of the range between 0.26 and 1.65 to see whether the values are very low, which could be a very high lambda protein being secreted, or very high. But they do establish the fact that you do have a monoclonal disease, either being MGUS versus myeloma. But the abnormal ratio does not allow you to discriminate between these two conditions. It does allow you to give a prognostic value to, and I'll show you that in a few slides, to who may progress into a more severe disorder from a more benign disorder, such as MGUS. MGUS is a clinical diagnosis. It requires a M spike of less than 3 grams per deciliter, like the first slide I showed. These people are usually not anemic. These people are normally not hypercalcemic. If they have an abnormal kappa to lambda ratio, it can be prognostic for those that might progress to myeloma. MGUS patients do not have osteolytic lesions, but they may fracture of different types of so-called osteoporotic fractures because they have a higher risk for fracture. And part of that we could get into, if you want to, in the discussion, the fact that these people have high bone remodeling. They probably have a very geared up rank ligand system in their marrow. Some of these may have a decrease in osteoblasts formation because of an increase in production of another protein from plasma cells called DKK1 or DICOF1 that inhibits the osteoblast. So these people have a number of reasons why they can have fractures and yet not have osteolytic lesions. MGUS can be a precursor of more serious diseases such as primary amyloid and obviously multiple myeloma. MGUS in most cases do not evolve into overt myeloma, and we'll show you how the FLC, serum FLC, can help give you some prognostic guidelines into that. In Abita's article in the Mayo Clinic proceeding 2009, in the Mayo population, 605 patients with MGUS followed for 24 years mean. Osteoporotic fractures are higher than controls, independent of the progression of myeloma. I think that's an underappreciated observation in the medical community, that these people that have MGUS have a higher risk for fractures and progression than people who are age matched and bone density matched who don't have MGUS. It's not a risk factor that was captured, for example, in FRAX. There wasn't data available then. So again, to point out some of the differentiation clinically of MGUS versus myeloma, MGUS is usually not anemic, they usually are not hypercalcemic, and they usually have a normal sed rate. Now, if somebody has MGUS and they also have rheumatoid arthritis, they can have a high sed rate just from the RA, for example. If you see people that are fracturing and have an elevated bone alkaline phosphatase, this is not related to myeloma. This is one of the clinical pearls that I like to use when we teach a lot. Because of the fact that MGUS patients and myeloma patients' plasma cells secrete this DKK1, which inhibits the osteoblasts from working, and BSAP is an osteoblast marker. These people can fracture. It's one of the few diseases that can have a lot of fractures and never have an elevated BSAP. Now, prognostically, the M protein is one of the prognostic indicators for the proportion that might evolve into myeloma. If the M protein is less than 1.5 gram per deciliter, the 5-year probability of progression into myeloma is 5% versus somewhere between 12 and 20% if the M protein by itself is 1.5 gram per deciliter. And I'll show you how adding the serum free light chains improves this prognostic indication. Again, these people need have high bone remodeling. In part, they may have high bone remodeling, particularly the osteoclast activity, because of the increased production of a protein that's in the marrow in these patients called rank ligand. Now, multiple myeloma is 1% of all cancers in the U.S., 10% of hematological malignancies, and has a higher prevalence in the African American population than the Caucasian population, nearly double in the African American population. The diagnostic criteria that's accepted by the NCCN, and these are Hematological Oncology Professional Societies, IMWG, is the acronym so-called CRAB: hypercalcemia, renal involvement, anemia, and bone involvement, which is usually not a feature in patients with MGUS. These are important clinical distinctions. In the marrow, these are plasma cells. You can see in the normal marrow, and in the marrow it's got an abundant amount of plasma cells. And again, the criteria is 10% or more plasma cells. So this is an important slide. The next two slides are the three things that we can take a look at, the big three risk factors for multiple myeloma from the electrophoresis and the serum free light chain. One is the level of immunoglobulin, the quantifiable M spike of over 1.5 gram is a stronger risk factor for progression of myeloma. The second one is the immunoglobulin subtype. Those that have the monoclonal protein that's IgG have a lower risk for developing myeloma than those that have IgA or IgM. And the third is the abnormal FLC ratio, whether it's below 0.26 or above 1.65. Either one of these can be prognostically important in terms of predicting progression to myeloma. And some guidelines that patients that may have A, B, or C, or 1, 2, or 3 should be considered to referral to your hem-onc for the consideration for the evaluation of the bone marrow. This is actually, the next two slides are reiterate this in a different way. This is hazards ratio, odds ratios, published again by the Mayo Clinic group. If they have an abnormal FLC, either a low one, so they have a lot of lambda production, or a very high, over 1.65, the odds ratio, where a ratio of 1.0 is no increased risk. This is 2.6. Again, the serum protein over M spike of over 1.5, and IgG is a lower risk as compared to IgA or IgM. So this is from that same paper looking at the 20-year progression all the way to the right-hand side of this slide to myeloma from MGUS. Low risk, an M protein less than 1.5, and a normal FLC ratio, and all the way down to the bottom is the high risk with all three factors abnormal. They have an M protein over 1.5. They have, for example, an IgM subtype, and they have an abnormal, either low or high, serum free light chain ratio. You can see if they have all three combined, the progression is quite high over a 20-year period. Going back to the thing that I deal with day in and day out, and that is their bone problems. These are summary slides from 4 different papers that are referenced here. Geriatric patients with MGUS had a significantly lower bone density than those without. The age matched. In postmenopausal women, vertebral fracture prevalence was much higher in MGUS populations than age-matched controls. And you can see that the type of protein they may have a higher risk for fractures than those who don't have those proteins. And I think that the statement that I made at the very beginning, that simply it's not vertebral fractures only, is bullet from the next one from the bottom, that the ones that have axial and peripheral fractures can have an increased risk for fracture. So the important point is that MGUS has a high probability of fractures. Now, what we do when we monitor these folks, monitoring MGUS for osteoporosis, we monitor their bone mineral density by DEXA, dual energy X-ray absorptiometry, and we do this either yearly, depending on the severity of the patient. We make clinical judgments here, or every other year. And there's C-telopeptide. C-telopeptide is a serum marker of bone resorption. It comes from bone collagen. It comes from the collagen cross-link. They're widely available assays. Medicare covers this. So again, some commercial plans do, some don't. And soon, as the field matures and evolves and we get better laboratory standardization, you'll see the biochemical markers of bone turnover being used more widely. We certainly use them in our referral population because we're seeing a sicker population, and we use these markers to see whether they're high, which is an independent risk factor for fracture as well, and whether they come down into a range that kind of reflects whether they're responding to bisphosphonates, for example, or denosumab, whatever anti-resorptive agent we're using to treat these people. Now, there's no clinical trial data on pharmacological interventions specifically directed at osteoporotic patients with MGUS, but since these people do have high bone remodeling, at least on some biopsies and by CTX, we make clinical decisions of who to treat, similar to some of the recommendations based on guidelines, clinical guidelines for treatment of postmenopausal osteoporosis patients, that is, people that have osteoporosis, particularly at the femoral neck, or who have prior fractures, certainly, or have the high FRAX score. FRAX is the predictive model, the 10-year World Health Organization model for predicting fractures of major fractures or hip fractures in the untreated population, and people that have high FRAX scores. FRAX for the osteoporosis population is like the Framingham for the cardiovascular population. Now, here's a couple of patients that we've seen recently, and the case one was a 67-year-old male who had presented with a low bone density. He was concerned about this. He had no fractures, but he was worried. We did a immunofixation. We did not see an M spike, but he did have an IgA monoclonal protein. When we sent this off to the commercial lab, they did the wrong test. They did the total light chain, not the free light chain, and that is not valuable. It doesn't give us the information that we need to tell us about these predictive models as the serum free light chain does. So we ordered the free light chain for this particular patient. So this capital lambda ratio was not useful because of the fact that it was done on the total, not the free. So here was and when we set off the free light, he did have a slightly elevated light chain ratio of those free. Ultimately, we did have a marrow on him that was not significant. This is case 2. This is a lady who presented. She was 59, and she presented with a vertebral compression fracture. She had here, you can see, she had an M spike, actually 2 different M spikes, a gamma, an I gamma down below, and on her, did her immunofixation, and here's her immunofixation showing a IgA monoclonal protein with kappa to lambda light chain specificity. Now you'll see the M spike up here. The M spike was low, so that would be more consistent with MGUS than with myeloma. But we had an IgA specificity on this particular patient. We did her serum-free light chain, and she had you can see this kappa to lambda ratio that was high. Again, over to the right, the normal reference 0.26 to 1.65. Now again, because of the fact that she had this high ratio, even though it's not diagnostic, it's prognostic for a higher risk of developing myeloma, we did refer her to our hematologist, and she did have a marrow that fortunately was normal. Now, we will be monitoring her with yearly immunofixation and serum free light chain ratio, because we'll use a combination of all those along with, we also monitor obviously her bone density, her markers, her SED rate, her serum calcium, to make sure that all these are consistent with the stable MGUS versus a progression potentially into a myeloma situation where we have to then refer back for management by the hematologist. So this is a consensus statement, a summary statement on MGUS. Who do you screen? The people that fracture, people that have osteoporosis, whether T-scores are lower or Z-scores, than you think they should be. I think it's a good suggestion in this particular guideline to do all African Americans because of the very high prevalence of MGUS as compared to the Caucasian population. Unexplained proteinuria, unexplained renal failure, unexplained peripheral neuropathy, other kind of people that we have with unexplained hypercalcemia, SED rates that are high that are unexplained. And when I follow these patients, I follow them on an annual basis with regard to monitoring these folks. So, I hope we follow what Albert Einstein suggested. And this is not complex. This is something that whether you're a very busy, real-world family physician, an internist, a subspecialist, following these two things particularly, the immunofixation and the serum-free light chains, will take you down the road of being able to make this simple for most particular situations. So in conclusion, both MGUS and myeloma are common disorders that are associated with osteoporosis and fractures, and that's how I get involved in these particular situations. Laboratory evaluations should include a simultaneous SPEP or immunofixation and a serum-free light chain, and it's more sensitive for detecting monoclonal protein and prognostic factor for MGUS or myeloma. The immunofixation and the SFLC can also be used to monitor progression, and I think that when you look at these people, you take these particular lab tests and the total clinical package of how they're doing in terms of monitoring these people over time. And with that, I will say thank you very much for being here, and we'll open it up for some questions.
Thank you, Dr. Miller. Audience, the session is now open for questions. You may ask a question by typing into the question and answer box located on your GoToWebinar window. Our first question is, do you screen all your patients referred to you for monoclonal disease?
I do, but now I do that because of the fact that I'm a referral practice. But I do think some of these recommendations, even if you're not a referral practice and you're in primary care, you're seeing these patients in internal medicine, I think that is an important thing to do for all your patients that have fractures. I think it's an important thing to do to all your patients who have, a lower Z-score of -2. I think that it's important to do in the people that have unexplained elevated SED rates, if you're doing that, or their creatinines are 1.5 and they have unexplained decreased renal function. So I think they're in the primary care world. I think there's a role for doing immunofixation and serum free light chains, even in not being a specialty referral practice.
Our next question is, what are some of the reasons for elevated kappa or lambda with a normal ratio in patients with osteoporosis?
Well, that's a great question. Thank you for that. Some of the reasons for elevated ratios can be reduced renal function or inflammatory disorders. These ratios go up in people that have, for example, not a lot of data, rheumatoid arthritis, lupus, or decreased GFR. You can see abnormal ratios. I'm sorry, the concentration. So I think the elevated concentration in terms of decreased GFR. So I think that there are other reasons why you may see abnormal concentration without having MGUS.
Our next question is, based on your experience, what % of your patients with osteoporosis have MGUS or a more advanced monoclonal disease?
Well, again, the answer to that question is a selection bias because I'm a referral practice. So we looked at this, and we have as many as the people who fracture, who get referred to us, who maybe already been worked up by their primary care doc without doing a SPEP and a serum-free light chain, could be somewhere between 10 and 20% of the people that we see. We see a very high number of, but again, that's a selection bias because we refer people who sometimes have already had a workup that has not included evaluations for monoclonal gammopathies. So I think we certainly think that measurement of 25-hydroxyvitamin D should be a standard of care, even at all levels of primary care in the evaluation of the osteoporotic patient. And the day may come when that's a standard of care for all patients who are being evaluated for osteoporosis. But certainly I think if you're in a primary care practice and you have patients with fractures, the fracture patients need extensive evaluations because that represents the highest risk group for future fractures independent of their T-scores. I think that people that are losing bone for reasons that you cannot identify, that's not from hyperparathyroidism or from hyperthyroidism or from celiac disease, other things to look for, you have to really look for these monoclonal disorders. I think people who may not be doing as well as expected on therapies, you should look for these disorders. So I think there's a group of people out there, even at the primary care level, that should routinely have either an SPEP or immunofixation plus the serum-free light chain.
Can you describe the role of inflammation in bone loss?
Well, that's a good question. I'm not so sure I can give you a real true scientific answer. We know that active rheumatoid arthritis, we know this from the FRAX modeling, the fracture risk assessment modeling, the 10-year risk assessment of the World Health Organization, that active RA was an independent risk factor for fracture, independent of the bone density. What FRAX did was to look at the interactions between different validated risk factors over a 10-year period. So the RA is in that model. We know that from the rheumatology literature, and of course my rheumatology colleagues can comment on this far better than I can, that there is a bone loss in the periarticular areas of the joint that you can see on X-rays and MRIs that they do to monitor these people. They have a higher fracture risk. It may be related to some of their inflammatory cytokines that these T cells secrete. It could be related to the fact that they may have higher levels of bone remodeling, not in all situations, but in some situations that might be related to the production of the overproduction of rank ligand in the bone marrow. So there are probably multifactorial reasons in these inflammatory disorders why the osteoclast and osteoblast and remodeling is increased. But it's a consistent observation in the FRAX modeling that, and it may be linked to the severity of the RA, although this has not been quantifiable as well as we would like it. But certainly they have a high risk for fracture.
What % of your patients also have renal impairment?
Well, since I don't do active nephrology in terms of taking care of nephrology, all my good colleagues in the area, but I get referred to the patients that have decreased GFRs and are fracturing, because often they require, particularly stage 5 or more advanced stage 4 CKD. That's a GFR below 30, and of course stage 5 is below 15. So I would say it's about 10% of my referral practice. It's going to get more because of the fact that LabCorp and Quest and the National Kidney Foundation have pressed to have the estimated GFR, the eGFR, put on your chem panels now. And they've done that because they want to have more people identified in the population as a population screening tool that have stage 3 CKD below 60, which is according to the NHANES database, is the highest prevalence increasing in the United States and worldwide of CKD. The purpose of trying to detect early CKD is to look for modifiable risk factors to prevent the CKD from progressing, such as early diabetes, such as undetected hypertension. And so more and more I get referred, it'll be maybe 10%, 15%, it's going to get more because of this early detection of CKD by screening with the estimated GFR on commercial lab reports. And it's also getting more because some of the cutoff points for bisphosphonates are not to use bisphosphonates in people with GFRs below 30 or 35. And so because I'm a bonehead and a nephrologist, I get a lot of these people referred for consideration of how to do pharmacological intervention in these people that have, early stage 4 CKD. I hope that wasn't too long.
Can you talk a little further about how to use markers of bone turnover, such as C-kilopeptides? What is normal? What do we expect the values to be in different pathologies?
Yeah, well, thanks. There's an awful lot of work being going on here because, bone turnover markers are not prime time for everybody. They should be considered in certain circumstances. But the National Bone Health Alliance, which is a large professional organization in Washington, D.C., housed in the National Osteoporosis Foundation, has an active working group of scientists and industry and professional societies who have come together to try to put the bone turnover markers in perspective and to see where we need to take the assays and the standardization and the harmonization of the assays so they do become prime time for clinical practice. Where I find, and of course, and you'll soon see, pardon me, a very nice paper from this group coming out in Osteoporosis International. I think it should probably be in the August issue. The first author is Dr. Doug Bauer, a well-known and expert in this area, epidemiology internist at the University of California, San Francisco. And we're trying to say where markers stand and where they need to go to make them prime time. Now that's, so keep your eye out for that particular publication if you're interested in this. What I think, for my referral practice, I use markers all the time, and I like, for the bone resorption marker is the CTX, and for the bone formation marker, the propeptide type 1 collagen, or P1 and P. These are both available commercially. The CTX, I think, has a lot of value in untreated people when it's high, particularly. For example, the normal reference range for a CTX in most labs is somewhere between 150 and, let's say, 750 picogram per milliliter. If you have a high CTX, there's a differential diagnosis. It could be high from myeloma. It could be high because it's a postmenopausal woman who has a more rapid rate of bone loss than is predicted by a normal CTX. There's some data, there's a fair amount of data suggesting that there may be close to a linear relationship between the height of the CTX and the rate of bone loss. But you can't assume that a 70-year-old woman who's postmenopausal, not on estrogen, who has a high CTX, has that because she's estrogen deficient. It might be from a number of things that can cause high bone remodeling, like MGUS, myeloma, hyperthyroidism, hyperparathyroidism, a recent fracture, for example, metastatic cancer to the bone. So, but a high value tells you that they have high bone remodeling and is an independent risk factor for fracture. So some people that have a borderline risk, let's say a 59-year-old woman with a T-score of minus 2.4 that might not fall into traditional guidelines for treatment of minus 2.5 or lower, but has a high CTX, does have a higher risk for fracture than somebody with a normal CTX. So I might start that patient on therapy earlier than waiting till later. So that has value to me. The other piece of information is for monitoring, because the CTX will come down with anti-resorptive therapies within 3 months. It'll change faster than you'll see a change in bone density. So if I have a baseline and get another one 3 or 4 months later, if it doesn't come down, it means the patient's either not taking the drug, they're not compliant, or they're not absorbing it. They may have unrecognized celiac disease. So I think you'll see a lot of use of this, of the markers in particular selected patient circumstances. The bone formation marker, P1 and P, it can also be a bone resorption marker, because as soon as you decrease bone resorption, you decrease bone formation. Its major application now is the monitoring anabolic agents, such as teriparatide, or under the brand name Forteo, which stimulates bone formation. And there'll be another anabolic agents coming down the pike where you can measure a baseline and 3 or 4 months later P1 and P and find out whether the drug is stimulating bone formation. I hope that's not too long.
Thank you, Dr. Miller. Our next question is, what does peripheral neuropathy have to do with myeloma? Why do patients with peripheral neuropathy require screening for plasma cell dyscrasias?
Well, I'm not sure. I'm not the expert on. I'm not the neurologist, but I'll tell you what. These light chains can accumulate in nerve tissue. They can accumulate in the kidney and cause kidney failure. So they can accumulate in other tissues. And I think it's probably the relationship between the accumulation of these in peripheral nerves that leads to a peripheral neuropathy. And that's probably as far as I can take that one.
Given that patients with symptoms of osteoporosis often present to rheumatology or primary care physicians who may not be thinking monoclonal gammopathy or multiple myeloma at their first diagnosis, for example, they order tests like sedmates looking for inflammation and vitamin D deficiencies, what do you recommend?
Well, I think that's a great question. Thank you. I think that I think when you're working up a patient for osteoporosis, I think that even in the standard workup, vitamin D should be there all the time. I think every professional society now, I think, would endorse that a standard of care should be ordering 25Ds. I think that in selected populations, particularly in people who have very severe osteoporosis, who have fractured, who maybe have lower Z-scores, that's the age-match data, that you should be ordering electrophoresis and an FLC. Whether or not that becomes endorsed as professional societies and routinely in the primary workup for all osteoporosis patients, I think we've got to get to that point in time in the future as we get more and better data to validate that. But I do think you should be thinking about it. And I do think that you should recognize that the MGUS patient will not have an elevated SID rate, that the MGUS patient will not have hypercalcemia, but that the MGUS patient can have osteoporosis and they can fracture. And so that has to be on your list of things of thinking about.
Another question along the same lines is, many of the symptoms with which the patients present to a GP are nonspecific. Is there a sentinel symptom or sign?
For MGUS, no. Most of these people with MGUS are asymptomatic. Now, patients with myeloma, because they often will be anemic or hypercalcemic, will have fatigue, nonspecific type of symptoms. But the MGUS patient can present with fractures. If they're going to present, they'll present with either asymptomatic, very low bone density, i.e. osteoporosis, or they'll present with a vertebral fracture or a hip fracture or a forearm fracture without having any other type of symptoms that you can see with myeloma. So that's why MGUS, because it's so common, I remember from the Mayo Clinic proceedings, by the time we get to, we're all living longer, that's the good news, right? But in that setting, you can find 5%, 6%, 7% of the population that may have MGUS, and might be the cause of their osteoporosis and their fractures, not simply because they're postmenopausal and estrogen deficient. And it's a higher risk group, so they have to be identified because you may treat them more aggressively at a lower T-score or at a better T-score than somebody who doesn't have MGUS.
Thank you very much, Dr. Miller, and thank you, audience.